is a cash paying patient. So he has a background history of post-prostatectomy, secondary to acquired of prostate CA, and this was 2 years ago. And however, his serial PSA, his total PSA's level has been normal throughout his treatment, before and after surgery. And also has a post-incision hernia repair 2 months ago. So he presented to us with abdominal discomfort for 5 days. This is like a preamble, Dr. Joseph. Anything to say?
Yeah, same complaint like last time, and I'll say the same thing. Abdominal discomfort is pretty much non-specific, and I'll ask and query what exactly does the patient mean. Does it bloating as before, or is it abdominal pain or distension? So I think I'll get much more information about this discomfort in your HPI before I start discussing the problem. Thank you.
Okay, thank you, Joseph. So in the history of presenting illness, so this patient reported an abdominal discomfort, which described fullness and bloated abdomen for 2 weeks. However, the discomfort has worsened for the past 5 days. And this is associated with heartburn and LS satiety, reduced meal intake over the past 2 weeks. So no abdominal distension or pain, and no swallowing difficulties or painful swallowing reported. Moreover, he reports worsening of nausea, which started 2 weeks ago, but over the past 5 days, this now has been become a bit severe. And no vomiting, and he reports to have normal bowel habit. Upon further questioning, his doctor told you he has lost weight significantly over the past 2 months, since out of post-incision hernia repair, and no report of fever or night sweat or cough reported. So he has no yellowish coloration of eyes and has normal stool color, no history of hepatitis B hepatitis screening, and no history of working in swamps, and no history of alcohol consumptions, and he is also a non-smoker. He reports no heat or cold intolerance, and he also reports a normal urinary habit. So he has a bit of significant past medical and surgical history, and significant also on family and social history. So as I said earlier, so he is a post-prostatectomy, which was a robotic prostatectomy done in India, secondary to acquire of prostate CA. A serial PSA has been normal throughout his treatment. Post-incisional hernia repair 2 months ago. 2 weeks later, during follow-up, he had fatigue, and then he was found to have an HB of 5 and transfused with 4 units of blood. So he also has a previous history of H. pylori treatment 3 times, but no treatment follow-up has been done to either declare whether H. pylori was eradicated or not. He has a family history of ovarian cancer, his sister, and died of it. So the pre-morbid dietary history was adequate for quality and quantity. However, the morbid dietary history, he prefers only liquid food, has poor appetite, due to poor appetite, and he is also unable to finish a single plate. So this was inadequate for both quality and quantity. Any comment, Dr. Joseph?
Yeah, thank you very much, Michael. That's a well-taken history and a lot of information to dissect there. So the job now is to dissect which informations are crucial that can lead us to find out what is troubling this elderly man, and maybe which ones are to leave behind. And some of them, especially in the past medical history, I think is to decide whether what do they mean exactly. For example, this patient had prostate CA. I think you say 2 years back, and only prostatectomy was done. So I believe what I'll be asking this patient is, how did they find out that was prostate CA? So maybe they, as I've seen around here, maybe they saw a patient who had lower urinary tract symptoms, and the diagnosis was maybe BPH. And when they did prostatectomy as a treatment for that BPH, when they sent the prostate for biopsy, came back said cancer. And then the question will be, what next was done? Because prostate cancer, you don't, the treatment is not only prostatectomy. You have to undergo cancer therapies, including some chemos and radiotherapy. So I'll put a very big mark there, and later I'll be thinking, is this what was called prostate cancer previously? Is it related? The PSA being normal doesn't rule out prostate cancer at all. Doesn't rule out prostate cancer at all. There are mechanisms to explain that. I think I cannot recall them by now, but I've learned throughout my practice that if someone, even if someone has a normal PSA, it doesn't rule out their possibility of prostate cancer. Then the incisional hernia. Is this, Michael? Sorry, you said which kind of hernia was this?
So this incision hernia was from the previous inguinal region where surgery was done.
So he had inguinal hernia.
Yes.
Okay. Yeah. So also that in the past medical history of that inguinal herniatomy, and then now comes this incisional hernia. This is also of importance in the past medical history because from there, from what I'm seeing this story, things started to come up. Like we're told the patient has a history of weight loss. I think it's the most important thing in this, all of this HPI. And when they did study, you look at it, you realize the around is 2 months, and the the herniatomy with incisional hernia 2 months also. So you wonder, 2 years of prostate CA, nothing, and then hernia surgery, weight loss, and other symptoms starts coming up. The abdominal symptom that this patient is having are pretty much non-specific, I can say, because things like fullness, bloating, with no pain, nausea, pretty much non-specific. But of importance here, patient has weight loss, and then they have an aversion to food. So if someone has weight loss, very few things that to consider. Of course, we have our mnemonic of anyone who is inflamed, but we're not seeing many evidence that this patient is inflamed, except for that weight loss. But so this patient is losing weight because of only this aversion to food, or the aversion to food is also caused by an underlying factor, and that factor also contributes to the weight loss of the patient. If you're talking about, let's say, malignancy that can cause a patient to lose weight, there are not so many. Most of them will be blood malignancies plus GI malignancies. And some GI malignancies, for example, malignancy of the stomach, they also present with one of the symptoms is aversion to food. Because Michael's not telling us if this patient is averse to food because he can't swallow. So he prefers liquid food, but we're not told. So that's the question also I'll be asking the patient, that can you swallow properly? Why are you preferring liquid food and not solid food? Or is that not, the patient is not feeling to eat at all? That's why is preferring liquid foods and lesser of that. So I'll say, Michael, again, of all things around here, I'll pick weight loss and aversion to food to be very important symptoms this patient is presenting with. And about weight loss, one way of said lower intake of food is one, but which the patient already has, but maybe there's something else underlying. Not many things that this patient is inflamed, and so I think many things will come from maybe the labs in this patient to see what is happening. But to remind everyone here, if you're seeing a patient who is losing weight, a quick screen will be, number one, HIV, diabetes, and malignancy, age-specific malignancy. A 70-year-old patient a lot of malignancy that can be going on. So I'll pause there, Michael, and listen for the further history.
Thank you, Dr. Joseph, for the nice and well elaborated um, history. So upon examination, so this patient was only had only conjunctiva power, and the BMI was 29, regardless the history that the doctor told that that his daddy has lost weight. So BMI is 29.4, and other vitals were within normal range. So upon systemic examination, he has only epigastric tenderness. Otherwise, the rest of the systems were unremarkable. Joseph.
Yeah, thank you. So the physical exam has some findings to be explained. When I see this patient is pale now, I remembered in the history, also Michael told us, around the time this patient did the surgery, there was also anemia which required transfusion. And you think of the surgery, it was, I believe it was not such a surgery to make someone bleed that much, robotic surgery, angiography. So you wonder, what we are seeing today, is it the continuation? Should we take into account that anemia that occurred some months ago when this patient underwent surgery? Is it not because of the surgery? And this patient we are seeing today, he is pale. For someone to see pallor, you have to have an anemia of around maybe 7 and below 8 actually. So at that time it was 5. This is severe anemia. And is this anemia not developed over these 2 months that we are saying? It was there even before. Maybe this is anemia which comes and go, or chronic anemia. So no one knows. But in a patient with anemia, the first question is maybe to ask, is this acute or chronic? For the way the patient is presenting, it feels like it's an acute anemia. It's a chronic anemia, because if you have an acute anemia to make you pale, to go below 8, you also present with other symptoms of anemia, like dizziness, headache, shortness of breath when you walk, and some sort of that, which we are not being told. So maybe the patient has chronic anemia. And then, so we'll order a FUBA picture and look at the FUBA picture, whether other lines of the blood cells are also down, and discuss it from there. Or is it an isolated anemia? The differential diagnosis is quite different. And then the patient on exam has epigastric tenderness. And in an abdominal exam, you palpate somewhere, you feel tenderness, you ask what organ lies below the area you're palpating. In this moment, that's the stomach. But also not necessarily. The stomach can be there. Some patients might be having pain coming from the gallbladder, and also you palpate there, they also have tenderness. But those patients usually also have tenderness on the right upper quadrant. Also, I think so let's say it's a pain, it's a tenderness coming from the stomach. It reinforces what I was thinking before. Patient with an aversion to food, weight loss, non-specific GI symptoms, and anemia is what we are palpating. Is the tenderness coming from gastric malignancy? So at the end of the day, this patient must be imaged, like with the CT plus the OGD, to look at what is that. But 70 years old, weight loss, aversion to food, epigastric tenderness, the priorities on the gastric malignancy. Concerning the anemia now, well, gastric malignancy may present with an anemia. I don't think of an anemia of 5 unless the patient is also bleeding from that malignancy. they might not tell us, even if we ask, have you ever seen melena stool? Maybe not. Maybe it's slowly bleeding. That's why in a patient like this, anyone above 50, and you ask GI symptoms like this, you also do stool for cut blood, because some blood might be occulted and not seeing them. Patient is not seeing them in their stool. So, Michael, I think we should move on.
Thank you, Dr. Joseph, for a very nice explanation. Actually, again, you have actually dissected it very well, and probably you are heading there. So, if I ask you probably to commit to your diagnosis to this time, or the list of differentials that you have before we move on to investigations, the provisional diagnosis and differentials.
Yeah, so at the moment, an elderly patient like this who is having weight loss, as I said, weight loss, think of, first of all, not many things. Blood glucose, diabetes can cause weight loss, HIV, maybe not right in this age, but possible. Lastly, malignancy. So age-related malignancy, any malignancy is possible at this age, but you look at the symptoms, they're GI, and I think malignancy of the stomach are higher up there, and they can explain, I think, most of the things that have been talked in this patient. Something else, maybe is the disease of H. pylori, and like it's a risk factor for gastric malignancy, and or PUD and chronic PUD risk factor for gastric malignancy again. So I think gastric malignancy will be up there, and if I told one thing to do in this patient, I would do an OGD.
Okay, thank you, Dr. Joseph. So, for the interest of time, so this was the initial CBC when I was attending this patient for the first time. This was in October last year. So he has anemia of 9.3 and a bit of thrombocytosis of 418, and other parameters you can see: microcytic hypochromic anemia. And this one was 1 week after the first CBC. So no intervention that was done. Still, the HB was 4.9, 9.4. It was microcytic hypochromic anemia, but hematocrit was keeping decreasing regardless. So these were the iron studies. So I was interested to see whether if there is anything going on. So these are the iron studies, as you can appreciate them. So serum iron was a bit low, with a total iron binding capacity of 20, which is also low, and ferritin was 20, which is also low. And so other chemistry that we were able to do at that particular point in time is that we went for serum creatinine, which was normal, with a GEGFR of 95, and electrolytes were within normal range, and serum albumin also was normal. So went for viral hepatitis screening, including viral hepatitis, and including HIV1 and HIV2, which were both negative. And then lastly, I said, okay, let me go for stool workouts, blood, CEA, and H. pylori surface antigen. So stool workout was negative, CEA was within normal range, and H. pylori stool antigen was positive. Joseph.
Yeah. So thank you. Yeah, the patient has a microcytic anemia, and I have a mnemonic for microcytic anemia. I think it is TAILS. So T for thalassemia, A for anemia of chronic illness, I for iron deficient anemia, and C, I don't know, but C, yes, I think. Oh, it's not C. TAILS. L is for lead poisoning, and S is sideroblastic anemia. Of this and how the patient looks like, most common usually iron deficient anemia up there. And Michael did the iron studies. So iron studies shouldn't be intimidating to anyone listening here. All these numbers, you don't have to think about them. Unless your patient is inflamed, just look at the ferritin. This patient is maybe not inflamed, we haven't heard anything. We can explain his weight loss due to not eating, for example, no fever, nothing else. So this patient, I can say, is not inflamed. I'm saying inflammation because inflammation rises ferritin. Ferritin is an inflammatory marker. So if patient is not inflamed, just look at the ferritin and slow say iron deficiency anemia, period. If your patient is inflamed now, you can also look at um, the TSAT. So the TSAT here, Michael is telling us it is normal, but the ferritin is down. I would take the ferritin and say this patient is actually when I want to look at the iron content of my patients because they're paying cash for this study, I usually just do ferritin if they're not inflamed. And this is low. I can say below 25, I consider it low. So we can explain this anemia is iron deficiency anemia at this moment. And now, if you say iron deficiency anemia, that's not a diagnosis. That's that's a proximal diagnosis. Means there's something distal to it. There's something else that should explain it. Now, what are the causes of iron deficiency anemia? A lot of causes of iron deficiency anemia, but easy things first. You ask, is the patient chronically losing blood from anywhere? And you say, yeah, this patient had uh, had anemia of 5 last time. Maybe it wasn't well corrected, and when it becomes chronic, well, it can look like iron deficiency anemia. That's one thought. But thought number two, if patient was female, you look at the GU. But patient is male, elderly, look at the GI. Is the patient losing blood from the GI? You can do a lot of tests there, including the stool for cut blood that Michael did. Now, the stool for cut blood is interesting. If it's positive, patient is losing blood through the GI. But if it is negative, it doesn't rule out the possibility that the patient can be losing blood through the GI. So you can't say I'm not doing OGD because this patient the stool for cut is negative. That would be a mistake. You just proceed if you are really convinced that maybe it's the GI. Do OGD and look what's coming out from there. If it's negative, then you consider other causes. But at this moment, I will still think this is the patient losing blood from the GI. Yes, H. pylori being positive, also very important in this patient. So a positive H. pylori is a risk factor for a peptic ulcer disease, which maybe this patient is having, but the symptoms doesn't tally to peptic ulcer disease alone. And even if the patient presented with abdominal pain and you thought maybe it's peptic ulcer, and they are telling you they're losing weight, and they have anemia, you have to go for an OGD. Or the reason why, because we don't want to miss gastric malignancy here. So maybe the tenderness is coming from gastric ulcers, but maybe not. Maybe there's a tumor in there, and this has been for some time, and it has not been treated. Yeah, so I think those were the labs to explain, unless I'm missing anything. Yes, the normal CEA. So yeah, CEA, I think being this is elevated, Michael. Yeah, 1.8 is elevated. So
It's normal for non-smokers.
Oh, it's normal.
Yes.
Sorry, yeah. And a CEA, you know, more useful in a patient who already has GI malignancy and it is elevated, and you're treating them. You are looking at the trend. How is it going? You're following them up. But diagnostic, maybe not so much. If it is normal like this, you don't say normal, no GI malignancy, because it is normal. But if you find this elevated, increases your possibility. But yeah, so I think that this CA being normal doesn't change anything of what I'm thinking, Michael.
Okay, so So as you have keeping repeating and repeating that you want to do an OGD to this patient, so you try to cancel the patient, and the patient said, no, I cannot go for OGD. And what are the reasons for this? And the patient is a bit educated. So what's the next step, Joseph?
Yeah, I find that in my practice also around here. Yeah, so I think we should let uh, patients decide their treatment, but we should make sure that they understand what they are deciding. So for me, what I would tell this patient is, I highly suspect you have stomach cancer, and maybe we don't know. Maybe it is treatable. Will never treat you. No one will treat you unless they know, is it really a cancer? Where is it? How far is it? And if we do OGD, it is not a cancer, then yeah, fine. We can treat your H. pylori, and you go home safely without the stress that maybe you have a cancer. So yeah.
Okay, so that's interesting, Joseph. So that's what actually I did. So I really canceled the patient, and the patient denied. So what I did is I actually took the number from the daughter, and give me your number. I think I need to talk to you personally because I think your daddy has malignancy. So what I did is, after 4 days, the patient agreed to do both. So I did a double endoscopy to this patient. So this was the pathological examination results. So from the colon biopsy, so this was high suspicious of adenocarcinoma, and the patient had multiple hyperemic polyps throughout the colon. And then from the GI, from the gastric biopsy, it was suggestive of an invasive, poorly differentiated adenocarcinoma with ulceration, intestinal type. So, Joseph, so linking the history together with this histopathological examination, what will be the diagnosis at last?
Yeah. Okay. Now, okay. So the first and foremost, the OGD, confirming what we were what we were thinking initially. In fact, poor differentiated adenocarcinoma with ulceration. So this patient has malignancy, but I understand what Michael says here. Now, there is if we did colonoscopy OGD maybe years back at 50, would the US screening guidelines say at 50 you should screen for malignancy. So this patient would have undergone maybe colonoscopy, and you would see polyps. And all colon cancers comes from polyps. Like initially they're benign, and then they transform becoming to malignancy. So if we did that 20 years ago, we would have found this. But now we are here, already have transformed. So this patient has polyps, malignant polyps in the stomach and in the colon. There is a name for this. Only David maybe can remember that, and some people in the chat, but I would have Googled it. I think it's something polyposis, I don't know, something like that. I can't recall it, but I understand it's a risk factor for cancers of the GI. Maybe someone can Google it in the chat and tell me, but there is a name for this. I can't recall it for now, Michael.
Okay, thank you, Dr. Joseph. So, so at last, I never also went straight to the final diagnosis, like whether it's a hereditary polyposis syndrome or it's Lynch or any other stuffs that are linked to the genetics of polyps and the GI malignancies, plus the history that we know prior that the patient presented with, and a very strong family history of ovarian cancer, where her first degree relative, the sister, had ovarian cancer. So other part of the history were a bit vague. So I thank you very much, Dr. Joseph, that we were able to actually pick what is needed from that particular history. For instance, the history that was this patient had a prostate CA. So to me, initially, it wasn't make sense. And the good news that I was attending the patient where the patient has been seen on the same particular system, same particular hospital for quite some time. So I was able to scroll down the history on the system to find out whether there is any documentation with regard to prostate CA. So at that particular moment, I thought prostate CA is misleading me. I have to search for another cause. So at last, I opted to go with the straight histological diagnosis that this patient has a gastric adenocarcinoma, gastric and colonic adenocarcinoma. But of interest today, I would like for us to discuss gastric adenocarcinoma. So on general overview, gastric cancers have higher incidences in areas where we can appreciate on the left here, has higher incidences on America and part of Asia. That's why ethnicity was very important to this particular patient today. It was very important to mention ethnicity and also some parts of Africa. But also we can appreciate that it's more common in male and with age of 60 plus. And our patient today was 70 years old. And there are a number of risk factors mentioned, including H. pylori infections, of which the patient also, it's true that the patient has recurrent H. pylori infection, but this does not explain or entitle to anything to this moment, other than probably this can be a two-hit hypothesis. This patient was already exposed, has a very significant risk for GI malignancy, and also has multiple treatment for H. pylori infection, of which also H. pylori infection is a standalone risk factor. So had double risk factor at this point in time. There are a number of risk factors mentioned, but to all of this, the patient does not fit to any. So other thing that is of importance is the pathogenesis you can appreciate from H. pylori, chronic H. pylori infection going down to atrophic gastritis, intestinal metaplasia, dysplasia, and then adenocarcinoma. This is how we go about. But histological classification, it is divided into two. We have the intestinal type and the diffuse type. But our patient fall into the intestinal type, which is the gland forming. And the other part of it is gross morphology. So the polyps, what they found in the OGD was polyps, and they were ulcerating tumors. So this patient also fall under this category. But there are symptoms of importance. The one that I mentioned above, epigastric pain, indigestion, weight loss. This one is bolded, and early satiety. So for elderly, we have to be a bit keen as clinicians once we want to attend elderly who are complaining of whether they complain or they mention weight loss or relative mention weight loss, and they have early satiety. And furthermore, red flags will be significant weight loss, also early satiety and anemia, which our patient presented with all of these three. Persistent vomiting, this is now a very late presentation, of which for patient with gastric malignancy, this will represent that this patient has already went to a stage of GOO, gastric outlet obstruction. So how do we diagnose, manage, and how do we prognosticate gastric adenocarcinoma? So there are a number of diagnostic workouts. We can go for endoscopy as we did to our patient, and then we can go for CT for the purpose of staging. And then we can also go for PET scan for staging either. But blood test, as Joseph mentioned clearly, I would like to underline the word clearly. CEA cannot be used for diagnosis. This is of importance, and that's why I shared the results of this particular patient. So initially I did a CEA, but this cannot be used for diagnostics. So if you have a high index of suspicion that probably my patient has malignancy, that index, you should not drop it down, say, the CEA is normal. So CEA to this patient was normal, and yet we ended up having a gastric and colonic adenocarcinoma. But the line of management can cut across from surgical specialties to oncology, even hospice care, which include palliative care and other stuffs. On prognosis, we have now to stage our patient to either by using TNM to stage 1 up to 4, but early detection has better outcome, and advanced stages have lower survival rate. So what are the key important factors to say whether this patient has a very good prognosis is if the patient is diagnosed at advanced stages. So to this case of today, for sure I cannot tell whether this was already a metastatic tumor or not, because the patient denied CT after the diagnosis and opted to go to South Africa for further management. So staging was not done at this particular point in time. But I have something in a nutshell to share today, either. So this is just in a nutshell. Stool positive H. pylori infection. So the updated guideline. As far as it's one of the risk factor, the other risk factor that we have seen to this patient that we cannot control if it's genetic, what we can do is at least pick it a bit earlier, as Joseph has said. We have to screen. If the patient has been diagnosed at the age, let's say, of 50, we have to minus 10, and the first degree relative and the family member has to be screened at the age of 40. If the first person is diagnosed at the age of, let's say, 40, we have to minus 10 again. So there are those as directed by different guidelines, gastroenterology guidelines. But of importance today, H. pylori is also a risk factor, and we encounter a number of patients with H. pylori in our clinical practice, from youth to elders. Now, of importance is, are we managing it the way it's supposed to be done? I know we have some issues with SDGs and other stuff, but let's see the updated guidelines. So according to ACGs, which of 2024, we can appreciate that according to the American guideline, European guideline, and the Asian guideline, BQT is now the first line recommendation. So we have to use the bismuth quadruple therapy, BQT. And if it's not possible, there are other medications that I mentioned, but the clarithromycin regime is referred as an alternative regime, the clarithromycin-based regime. So to me, I would like to pose a challenge to us as clinicians. So key principles that are shared by all guidelines that we see from American, European, and Asian, that treatment has to cut across. The bismuth quadruple therapy is a preferred first-line option in most cases. Choice of regime, this depends on the local antibiogram of a particular place. But in our setting, as we know that we do not have that local antibiogram. So we either opt to go with the BQT, which is currently available, if the patient actually can afford. If not, we have to use other treatment regime. But of importance that I was interested while I was reviewing this is the concomitant quadruple therapy that you can appreciate here in the European guideline. It's a concomitant quadruple therapy. If high clarithromycin resistance, what we can do is PPI, amoxicillin, clarithromycin, and metronidazole at the same time. And it's also a quadruple therapy. So for me, I found like, okay, this will be a very nice regime in our setting. As far as bismuth is a bit expensive. So for this one, I think will be a take home to me and to everyone who will also prefer this particular regimen. Otherwise, do you have any reflections, Joseph, before I give out my reflections of this case?
Thank you very much, Michael. And people might think maybe Michael is a GI specialist or something. He was out of residence, I think, just not even a year, Michael, right?
Yes.
Yeah, I'm very proud of you. You're such an astute clinician, and you're teaching. Do you teach at university? I don't know.
No.
Yeah, your teaching is extremely good, and you've touched very important points there. So, nothing to add. Very nice case. Thank you very much. Keep bringing those cases.
Thank you, Joseph. So, to me, the reflection from this case is I would like to share the sad story about this case. One is this patient has two relatives who are doctors, and they are both specialists. So the good thing about this case is having too much people surrounding you doesn't mean that are within the field, doesn't mean that probably they will be able to sort out your problems sometimes. And we know that within the clinicians that we do not treat families members. So this patient initially denied the OGD because he was like, I have a lot of family members who probably we will be able to sort out this. Why are you telling me this at this particular point in time? So they have money and everything. So sometimes you as a clinician, we as clinician actually, we have to stand on what is our high index of suspicion. This is my reflection to this case. If you suspect something, you have to use all means possible. We have to use all means possible to make sure that we reach out to whether to say is it there or not. 2 weeks, 1 month after the diagnosis, this patient went to and start presenting with the vivid features that were probably occult at the beginning. So starting presenting with upper GI bleeding. So he was admitted with an upper GI bleeding and transfused again, cancelled again for CT and then denied, and then admitted again with a lower GI bleeding. These symptoms were not there. So in December last year, is when he opted to go to South Africa, where now I missed the follow-up of the case. But so these are the reflection to this case on my side. David, to your side, brother.
Yeah, thank you very much, Michael. It's been a packed 2 weeks. So the case last week and this week again, I know that Joseph had a lot of fun discussing them. So thank you very much, and for the teaching points, which I personally think are very pertinent, and we have solid material to carry with us. So we still have a number of minutes. I see some comments in the chat. I'd like to welcome the audience. If there is anyone who would like to share anything, who would like to say anything or ask questions, anything before we close. Yeah, I do not see any hands so far. So we've had back to back two cases from Michael. Now I'm not sure who will come next with the case, but I make the same call that we make every time, that please bring your cases, because we want to learn from them. You see, uh, Michael brought some very good cases, and I think at face value, someone would say, why would someone bring let's say someone who presented with abdominal discomfort, and then it turned out to be a gastric malignancy, a diagnosis that Joseph, I think, started with right from the very beginning. But you can see that there was a lot of things to be discussed, a lot of dilemmas, right from history, physical exam, as well as around investigations. So uh, you do not need to have the very rare cases. So in other parts of the world where horses are more common, they talk of zebras. I mean, the zebras are more rare for them. I would say in our setting, maybe you do not need to bring a case which is an equivalent of a horse. So we even common cases that have something to learn from. And also, a case does not need to have a final diagnosis. You can bring a case which has no final diagnosis, and who knows, maybe we can come with a final diagnosis at this on this platform. So please bring your cases, and also volunteer to discuss. Otherwise, if there is nothing else, it was good to have you around. I know that for some of you, that's a lot of sacrifice. You decided to come and learn instead of enjoying soccer matches, for example. So that's a lot of determination from you. So good to have you today. Have a good night, and see you next weekend.